Hey, y'all. Professor Goodwin. We're going to talk about a few things this week for evolution of nursing thought and action, and we'll get right into it. Or not. There we go. All right, so here's some information on the most influential persons in the evolution of nursing. And as I always say, I want you to check out your book on this and understand all of the pieces that all of these people have had a part in. But most importantly, most notably is Florence Nightingale. You've probably heard of her, unless you've been under a rock. But now that you're in nursing, you're definitely going to hear of her a lot. She was an early advocate for quality healthcare, not just a nurse, but in all forms. She was very professional, used her clinical judgment and political connections to ensure that nursing became more recognized as a respectable profession. She started a school in 1860 for nurses. It was considered to be the first nursing program. Now, she was very focused on, and one of the very first clinicians to understand the idea of health promotion and also some of the ideas of infection prevention. And so read about her. She did some pretty amazing things, and you'll hear about her quite a bit. The rest of these, I want you to know about them, but you don't have to know extensively or memorize any of the specifics. Just get an idea for who they are and what they've meant to the profession. Okay, so a clicker check. Which individual provided care in the tents and was the founder of American Red Cross? We didn't go over this, but when you read your book, you'll see that Clara Burton was the founder of the Red Cross. Okay, so safe and effective nursing care. So we've had a lot of individuals that were important, right? We talked about Clara Burton. We talked about Nightingale. So we'll in general talk about some of these ideas, but I'm not going to be focusing on each individual person, except for perhaps Florence Nightingale. So as we know, Florence made a tremendous difference in the care. She was largely involved in war efforts, and so she drastically improved some of the outcomes based on her experience there. And she implemented interventions to promote not only improvements in care, but client comfort. So she led a primary goal that was focused on the comfort of the soldiers. And these are all the reasons why she was highly regarded. And she actually was credited with educating patients. So all of these things were very new ideas in nursing when she was involved in it in the late 1800s. Okay, so today nurses are competent and caring professionals, right? And when we say a professional, we mean it's a profession. So the 2 points that we focus on is that we're caring. We care about what we're doing and that our patients are well cared for and receive good care. And we're also competent. And what you're doing now is part of competence. You're orienting to the profession. And then when you take your NCLEX, that will be a basic competency entrance into the profession. The complexity of what we deliver requires us to be critical thinkers, good communicators, fairly organized. There's going to be leadership that's necessary because you'll be leading others eventually. We advocate for patients, and we have the technical skills to carry that job out and ensure quality care. It also requires clinical judgment, and that's why we're in school, right? The clinical judgment requires a strong, solid knowledge base. It involves a process that consists of recognizing and analyzing clues, prioritizing hypotheses and understanding other cues, and obtaining solutions. And then we are also focused on taking action to evaluate our treatments and then understand outcomes and reorganize if necessary. Clinical judgment is part of what we learn, right? Critical thinking is part of what we have innately, but also develop over time. We can't necessarily teach you everything about critical thinking, but we focus on that because the difference between clinical judgment is that it requires the education. Critical thinking is a reflective process. And so that involves collecting information, analyzing the adequacy and the accuracy of that, and then carefully considering options. Okay. And so we use this critical thinking in every aspect of our care. And sometimes it's the difference between a good and a great nurse. So we'll be developing that on an ongoing basis, as will you. For problem solving, this is a process unlike the other two where the nurses consider an issue and attempt to find satisfactory solutions. You'll use this throughout your professional life, but all these three are distinctly different situations, and we use all three of them in our professional lives. Okay, so the American Nurses Association in 1980 established the profession of nursing, and we'll go into some of the definitions in the following slides of nursing practice. But they said that the diagnosis and treatment of human responses to actual and potential health problems is what our description is. And here's a little bit more on nursing practice. So nursing practice, we have demonstrated that it's individualized, right? Every patient gets custom care. We establish partnerships with other clinicians. We also focus on the idea of care. It's central to what we do. And so we're very focused on that. You'll hear the word thrown around a lot, not just nursing care, but caring about the experience. We use the nursing process that we teach you to provide individualized care to our clients. And a strong link exists between our professional work and our ability to provide quality and healthcare and achieve optimal outcomes. And there's a lot of studies out there that point to good staffing, good RN staffing and availability, and improved clinical outcomes. In 2015, the ANA talked about nursing as it's the protection, promotion, and optimization of health and abilities, prevention of illness and injury, facilitation of healing, alleviation of suffering through diagnosis and treatment of human response, and advocacy in the care of individuals, families, groups, communities, and populations. So as you can see over the years, it's changed quite a bit and become more sophisticated. Why define nursing? Well, number one, it helps us, it helps the public understand our value as professionals. It helps differentiate activities in nursing from medicine, which sometimes is important not only for our own profession and standards of care, but for our patients to understand what our role is. And it also helps students understand what's expected of them. And then when I say students, I mean us and also new nurses and things like that, people that are learning. And you're pretty much always learning in the hospital, right? Somebody's always on that journey. Important qualities for nurses. And you're not surprised by this probably, but critical thinking, as we talked about before, is really essential, and it's not always present fully. So if you have that ability, or if you develop that ability, it will help you differentiate yourself from groups. Being caring and compassionate also differentiates yourself. Being detail-oriented is a strength for sure in nursing, because we're holding people's lives in our hands. Being organized is something I talk at clinical about all the time. Not everybody is born organized, and if you are, good for you, but you have to work at the skill of being organized. Some people more than others, but you can develop that skill. You just have to find your system and then use repetition to help you become decrease variability in what you do. And being organized in your skills actually helps you be safer. The more you repeat the same processes, the more likely you're able to give safe care. Of course, speaking skills are important. You're going to be educating patients. You might be giving lectures eventually. Listening skills are definitely important and underrated, I think. We've talked before about skipping over the subjective part and just getting to the objective part in our assessments. the listening is really where you get a lot of those things that you wish you would have connected earlier. So that's important. Patience is important, and I'm not talking about the ones laying in bed. I'm talking about being able to get through stressful situations and frustration without taking that out on other people. And everybody struggles with that. But you've probably at some point met someone in a profession, maybe not nursing, but who is clearly you might call it burnout, or you might call it care fatigue, but they don't have their patience anymore, and you can see that in their daily routines. Competence, of course, is important. Our patients trust us to be competent, and we fulfill that duty. And emotional stability. Um, it's not necessarily something that everybody has, but it is definitely a credit. And not everybody has emotional stability all the time. So, you might have colleagues or yourself going through major life changes, and that can be stressful on anybody. And nobody's always going to have an easy time with things like that. So we give each other grace, but at the end of the day, you have to be stable in order to encourage your patients and for them to trust you. And then physical stamina. Is this is it essential in nursing? Yes, it is right now, because nursing is a difficult profession. There are certain roles that require less physical stamina, and if that's not your strength, you can eventually sort yourself into those areas, and that's not a problem. Some people have difficult times in nursing school because they aren't cut out for med surg, for instance, but they'll find when they do that time and then they move on to whatever else they find, they might find something they love that is in a completely different area. All right, so are we a profession, occupation, or discipline? Now, this is an important distinction to make, okay? We emphasize that the definition of a profession and occupation are very different, all right? So a profession is requires technical and scientific knowledge, all right? The other thing too is that we are evaluated by a community of our peers, and that refers to research and things like that. We have a service orientation, so we're part of a service. And then we also have a code of ethics. That's a huge part of it as well. Those four things are the main things that stick out in making us a profession as opposed to an occupation. So in an occupation, some people make the mistake of calling this an occupation. Now, I don't really think that this is something that happens too much anymore. I think people really see nursing as the complex job that it is. But 20 years or so ago, there was a different view of it. And then 40 years ago, there was a very different view of it, right? You were considered to be just an assistant of the doctor. And that's a very different situation now. Although we do still continue to extend and facilitate the doctor's care, and that's a good thing. We have our distinct identity. And so some people might call it an occupation or a job. Most nurses are hourly, and that's one of the things that can often be common in occupations. The employer decides the conditions of practice and the nature of the work in a lot of situations. If you're an entrepreneur or you take other roles, you may not be in that situation, but the bulk of nursing is like that. And then nursing practice acts don't prevent us from functioning more autonomously. All right. So that's things that outline the differences. And then the final difference is discipline. So to be considered a discipline, a profession must have a domain of knowledge that's theoretical and practical, and it has boundaries. Okay. So the theoretical boundaries is like this. The profession is, these are the questions that arise from clinical practice, and then we investigate those through research. We have a rigid process for doing that. Practical boundaries are the current state of knowledge and the research and the facts that dictate safe practice, things like evidence-based research as well. So you could give examples of nursing domain of knowledge and theoretical boundaries and practical boundaries, but essentially we demand mastery of all of those skills as you go along and become a more mature provider. Okay, a little clicker check here. One factor that prevents nursing from being described as a profession rather than a job. Um, so this is something that keeps the job mantra going. So is it knowledge, nursing knowledge based on specific scientific knowledge? Nurses create a plan of care using nursing diagnosis. Most nurses only work to earn a paycheck. And D, in general, the work of the nurse is determined by the healthcare facilities as employers. And so we talked about nurses being paid by hour, but most nurses only work to earn a paycheck. That's not the same thing. Nursing creating a plan of care using diagnosis, that's related to research. That would be more on the side of the profession. And our nursing knowledge is based on scientific knowledge, also a profession. So we'll go with D. And that is the organization dictates the work routine. And so a profession is usually more autonomous and has more control over their practice environment. All right, so how can we improve our recognition as a profession? Well, there's a couple of things we can do. Number one, what we can standardize our educational requirements, which we have, right? We have uniform continuing education requirements. So for nursing, for instance, you will, in California, you have to get 30 continuing education units. They used to call them CEUs. Now they call them CEs. They're continuing education hours every 2 years when you renew your license. Okay, so you have 30 of those, and that's essentially 30 hours of continuing education. We increase participation of our nurses in professional organizations. UC Davis, one of the strengths that they have is their involvement in community research. So their nurses, as part of their clinical ladder, they call it, they have to progress by doing certain projects and, speaking in front of people and doing research. So that's part of their process, and that's a strength of theirs. We also educate the public about the true nature of nursing. So let's talk a little bit about why you should belong to a professional nursing organization. I always encourage this. Number one, because you get access to all the latest information. You can educate yourself. Number two, you start to become aware of conferences and other things like that. You will probably receive journals, and all of those things help you become more widely read in your profession and help you be a better nurse. So the educational requirements and things like that, that's standardized by the state. So everybody's different, but what's nationally organized is a professional nursing organization, and that applies to all areas in all states. All right, so nursing education. So there's a couple different ways to become a nurse, as you guys know. Some people aren't aware though. There are diploma programs that are still out there. These are hospital-based, basically on-the-job programs. Although they do have lecture components or didactic components, and that's a 3-year program, and that's without any college credits, I believe. And then we have the associate degree program, which you're in. That's a 2-year program in community college. Now, what people don't often realize is that that's 2 years after you've already done your basic prereqs and all of those things, right? So it essentially comes out to be 2 years plus 2 years. And then you have your baccalaureate degree programs, which are essentially the same amount of time in colleges and universities, and you come out with a Bachelor of Science in Nursing. There's some differences that are between the two. Like there's some things about the baccalaureate degree, like the community health rotations are more extensive and some of those types of things. But one of the things that we're trying to do is to get more baccalaureate and master's degree prepared nurses. So a lot of you may be doing the associates to, I think it's to master's or at least the baccalaureate. I recommend that you do that. It's before, if you already have kids, then you're already in school and you've overcome that barrier. But if you're single, you do have kids later, it can become more difficult. Plus, you're going to be working 40 hours a week, right? So as difficult as school seems like it can be, and it is, in some ways, you're more free now than you'll be in the rest of your life for this opportunity. So I recommend it as soon as possible. So we have, like I said, we have an RN to BSN program. That is something that Sac State has, and many of you have already applied for. Okay, so we talked about the first three of education. You can get your RN through the ADN program and then get your BSN. Or like I said, some places even go ADN to MSN, RN to MSN, and then doctorate. The doctorate in nursing practice is either a PhD or a DNP. A doctorate in nursing practice is more clinical in nature, and a PhD is more research focused. All right, so in a master's program or graduate degree program, they prepare nurses to function more independently. So not all masters are nurse practitioners. Like, for instance, I have a master's in nursing administration, and that's not a clinical licensure. It's not a progression of my license. But if you go for a nurse practitioner, which is a little bit more work, a clinical specialist or a nurse educator, nursing informatics, nursing administration. So it usually takes about 2 years to complete those. But if you're going for an advanced clinical aspect, there's more clinical time and there's a little bit more classes, like for a nurse practitioner. Doctoral programs, we talked about this. Pretty straightforward, and you'll get more exposure to that as you progress in your career. Continuing education, we talked about. This is required by state, and it's different for everyone. In California, there's a reciprocation, so you can go to other states and it counts. I don't know what all of the states do, but there's a difference between continuing education and in-service education. So in order to provide continuing education, like for instance, a business that I own outside of school, we have a California credentialed provider license. So we're able to give CEs to people for training that we give them. But many hospitals have that ability in their education departments, but not all of them have that. So sometimes you'll go through training at your hospital and they won't have that. And so it'll be in service, but you won't get any CEUs for it. CEs. Sometimes they will give you CEs for that. And that's always nice because it gives a little bit more incentive for the nurses to be involved, because there's something that they have to attend to anyway, right? And a lot of my CEs I get from going to conferences because I really enjoy those educational experiences. And I found over my career that no matter how I'm feeling at the time, if I'm feeling burnout or frustrated, once I go to that conference and I hear everybody else talking about the same challenges that they go through, it gives me more of a renewed perspective when I go back. So I'd encourage you also to attend those as much as you can as well. All right, so maybe you guys have heard of Benner. Benner's pretty cool. It's been a long time since she came up with this, but this is still applicable today. So this is the phases of nursing. This is the phases of learning, okay? So when you're talking about the novice nurse, this is us, right? This is where we are right now. Has very little nursing experience and is the first stage of acquiring clinical knowledge. You're focused on learning and focused on following the written sequences and the processes. Now, you're technically pre-novice because novice is going to apply to you mostly once you pass your NCLEX and you are at your basic competency level. Stage 2 is an advanced beginner. So that's when a new graduate starts to function at this level after a bit. An advanced beginner starts to focus more on aspects of a clinical situation, uses more facts and understands similarities in situations. So you can distinguish abnormal findings, but you can't really understand their significance yet. So some of us might be heading in that direction, right? And so we're probably more novice, but after your NCLEX, hopefully we have you about close to flirting with that stage 2. Stage 3 is when you achieve competence after 2 to 3 years of nursing practice in the same area. So when we say competent, we don't mean competency, right? So there's a difference between achieving a minimum competency standard and being competent. And so this requires 2 to 3 years of practice in that area before you become uh, able to handle the load, prioritize situations, and provide that care safely and effectively, and then also manage complex situations that can come up occasionally. Then you get into, and a lot of times there's a big distinction between competent and proficient. The proficient nurse is able to quickly take in all the aspects of the situation and immediately start to cluster and give meaning to the assessment data. We seem to see the big picture as opposed to just being competent. And so we can coordinate services, anticipate needs. So we're more flexible and fluent in our role and able to adapt to almost any clinical situation. And then you have an expert. The expert nurses are able to see what needs to be achieved, how to do it. They trust in their intuition. They operate with a deep understanding of a situation. They can recognize a problem even in the absence of classic signs or symptoms. They have expert skills that are often reached out to for other people, right? They're the ones that everybody says, well, let's ask Sue or whoever, right? And so that's your expert on the floor. And that's not the same as an expert that's on, one of the news channels, right? You don't have to be the preeminent nurse in the world to be the expert. All right, so regulation of nursing practice. There's a couple items that regulate our practice. Number one, the Nursing Practice Act. In the US, each state has its own Nurse Practice Act, and that governs the practice of nursing. And the state board of nursing, whatever it's called, there's some different names per state. They're responsible for regulating that. So they're charged with protecting the health, safety, and welfare of the public. And so you'll see like the California Board of Registered Nursing. The California Nurse Practice Act, and that's put together by the state. The State Board of Nursing is that Board of Nursing is responsible for, number one, approving nursing education programs, as I told you about that. Not only schools but CE providers, defining the practice of professional nursing, which is really helpful. Establishing criteria for people that need to be licensed. For not only in this state, not only RNs, but also LVNs, although there's a state board of LVNs, I believe. And so that all defines what the practice is and the scope of our profession. And then finally, there's licensure and scope of practice, right? So the standards of practice dictate what is appropriate for our role. The scope of practice is the boundaries around what we can do. So licensure is indicated and initiated by the state after we take our licensure exam, right? Which is called the NCLEX. And there are some reciprocation between states on that, and California is not one of them at this point, but I think it's called the Nursing Compact. I think California is about to join that compact so that you can practice in other states without having to go and take another test or qualify for something. And then professional standards in the standards of practice. These are statements, authoritative statements that apply to all registered nurses, regardless of their role or their population. And they're, things around like competence. So the American Nurses Association puts this out, and these are standards that provide a guide to us for knowledge, skills, attitudes, and boundaries. All right, so clicker check. Which of these organizations is responsible for regulating the practice in each state? State Board of Nursing, the state legislature, ANA, or the AMA? So we talked about the AMA and the ANA are not responsible for regulating the practice. Okay, those are professional associations. They are in some ways responsible for dictating the standards of care and ensuring that. But and the state legislature they enact laws. They're not responsible for regulating the practice. So that leaves us with our State Board of Nursing. Okay, so other professional organizations. the ANA, we talked about that. That's a national professional organization, American, right? The National League for Nursing. They also have a universal standard of education that they establish. The International Council of Nurses, and this is a sort of a federation of nursing care that's focused on quality nursing overall. They have global health policy initiatives, and they try to improve health worldwide. Okay, a couple more. The National Student Nurses Association. This is for you guys as nursing students. The Sigma Theta Tau is an honor society for nursing, kind of like a Phi Beta Kappa or some of those, and they're essentially joining them has a certain requirement that you have a certain grades and things like that. And it's just to support ongoing nursing scholarships, leadership service, and research if that's something that you're interested in. And then you can have specialties, right? So everybody has a different, well, not everybody, but a lot of people have different specialties in nursing, right? So there's a clinical specialty organization, and that would be something like the Association of Perioperative Registered Nurses, which is AORN, the Academy of Medical Surgical Nursing, which is AMSN. The ENA is the Emergency Nurses Association. Within that, they have certifications, right? So in the ER, let's see if I can think of one. They have the, I can't think of it now. Well, let's give the med-surg. So they have an RN C, right? Or RN BC for leaders. So that means you're a medical surgical nurse certificate. You're certified. So you're board certified. You have to take a test and pass in the core ideas of advanced care. And so I have the CNOR, which is the operating room certification for that. I used to have the CPAN, which is the post anesthesia care certification for that. So those are great things to have in differentiating yourself clinically. And so as you get more structured and feel more comfortable, I recommend that you try to do that. All right, so recipients of nursing care. So we do this to lots of different people, right? We provide care to all sorts of people, and we focus on health promotion, illness prevention, restoration, end-of-life care, and 100 other things. And so all of these things are applied to different groups differently. So when we're providing it to individuals, we might call them patients, clients. Some of those things are commonly used. We might provide them to groups, right? I might be educating a group on in a nursing home on falls precautions. And then we're going to be educating families all of the time, right? And helping them, maybe training them to learn how to do a home health procedure for their family member. And we might even be involved in community health aspects. Maybe you work for the CDC as an epidemiologist, right? Or maybe just working in a smaller community organization. Okay, so we provide both direct and indirect care. And so the direct care involves us interacting directly with the clients. Okay, and that's like giving medications or teaching. The indirect care is a little bit more of like working on behalf of them. So maybe I'm ordering unit supplies, or I'm working on a committee in the hospital, working on care experience, right? So those are things how we serve them indirectly. As far as nursing care, we provide care and we achieve goals of health promotion, illness prevention, health restoration, end-of-life care. We talked about this. These aspects cover all the services in the health spectrum, from complete well-being to death. All right, a couple models of nursing. We're going to go into this just briefly, but the models of nursing care, the case method is another term for total care. And this is one-to-one care the nurse provides every aspect of care for one client during a single shift. Okay. So that would be an example of this would look like intensive care, for instance, on a brand new intensive care patient. So the thing about this method is it's really super satisfying for clients and nurses, but it's very high cost, right? Functional nursing is where the care is compartmentalized. So each task is assigned to a staff member. So an example of what this would look like is it's sort of like, let's see. So you have one nurse that's in charge of moving patients. You have an IV nurse. You have an RRT, rapid response team. You have a medication nurse, and then you have the primary care nurse, right? So those are all different things. And sometimes it can be more efficient than the one-on-one, but it's still very, functionally expensive, because if you don't have IVs to do, then the nurses aren't working on patients necessarily, right? So there's a drawback to that. But what it does do is it helps people become very highly specialized, but they also become less specialized in areas they don't get to touch anymore. Team nursing is a little bit more of about, like for instance, when you have a nursing assistant and you have an RN working together, right? Or you have maybe you're working in a rehab unit and you have case managers and physical therapists and RNs. That's the team nursing model. That can be really pretty efficient depending on the area. It can be helpful for a situation where you have high acuity clients and you need nursing to focus. Team nursing is popular during nursing shortages, so might become more popular as we go along in the next few years. In primary nursing, one nurse manages the care for an entire group of clients. So this person assesses the client, develops a plan of care. And so an example of, and so they're completely responsible for all care. In their absence, like let's say they would go away on a vacation, someone else has to step into that role and fill the same role. Okay. And so that's something that might look like a case manager. I'm just managing this patient, although I might manage more than one patient. I'm the only nurse that's touching this, right? Or a nurse navigator is sometimes somebody that will manage a cancer patient so that they don't fall through the cracks between the different transitions of care. And differentiated practice is a variation of primary. And so it just sort of, each unit has identified expertise needed by the clients. And then once that's been developed, individual nurses put together a portfolio to demonstrate their competencies, okay? The thing that you might see out there most commonly is the total care, and then you'll see that at UC Davis. There are no CNAs, right? So it's a nursing-centric model, and you're going to do everything from change garbage cans to clean patients up. But there's not going to be that communication issue or fragmentation of caregivers as much, but it's also a very expensive model of healthcare. All right, so and going back a little bit, the least expensive model of healthcare is the one that allows the nurses the most flexibility to pivot and address needs as they come up. Whenever people are waiting for situations to happen because there's a barrier there, maybe because the union doesn't allow them to do certain things, those are all things that increase the cost of care, right? So when developing a plan of care or a system, you want to try to find something to where the nurses can complete multiple roles at the same time in order to everybody always providing care for the patients. So in a delivery system, we have a couple different types of care. Acute care is it's like the hospital, right? To treat active, sudden, unexpected, or urgent or emergent episodes of injury. Okay. And that doesn't necessarily mean trauma or something like that. It could just mean unexpected, serious conditions. And then on contrast, long-term support services is more human assistance, assistive technologies and devices. This would include places like clinics, non-hospital settings, extended care facilities, ambulatory surgery, and home healthcare agencies. Okay, and you'll see more of a transition away from acute care to long-term support services as we go along. All right, so hospitals are the most expensive and most frequently used sites for care. Okay, as we have come through the 2000s, there's been a lot of building of alternative care locations. So ambulatory care, they usually call it. So clinics, ambulatory surgery centers, and models outside the hospital. In fact, and there's you would never believe it, but most states, including California, particularly before COVID, were closing hospitals more than they were opening new ones. And this doesn't sound like it makes good sense, and some people would say it doesn't. But and that's when they say the hospitals are full. They're always full because the state is constantly trying to manage capacity, and it's become less and less necessary for the population to be in the hospital because we have alternative venues. So that's a constant push and pull about that because acute care hospitals are very expensive. At one point, and this was 20 years ago, I'm sure it costs a lot more now, but a hospital costs $1 million a bed. And so if you look at UC Davis Hospital, there's 600 beds, and do the math on that. I'm sure the ones that they're building now are probably probably 5 million a bed. And so it's a very expensive thing to build a permanent inpatient facility. And the largest part of healthcare costs is actually the labor. So nursing, medicine, and all of the clinical employees are a huge part of what that cost is. Extended care facilities. This is like your assisted living and rehab centers. We talked about the ambulatory care. This might be anything from a clinic to an ambulatory surgery center. And then there's home health care. A lot of people want to be at home for whatever they can in their health. And there's a lot of movement towards more home-based care. And then also community health or public health centers. So these would be like your free clinics or the things that they might do at your school to help student populations or homeless services. And then there's even private organizations like churches, schools. Actually, schools wouldn't be private schools, I guess. So you'll see those as different parts of the model as well. All right, so types of services. Primary services are directed toward keeping the client well and promoting illness prevention. All right, so this is your offices, clinics, diagnostic centers. It's mostly focused on health promotion and disease prevention. Kaiser Permanente's model was one of the first as a health maintenance organization, or HMO, to focus on that part primarily. And what they found when they did that is that the costs of the secondary and tertiary services, which we'll touch on in a second, went way down. And so that became a very innovative model for healthcare so that people could, the organizations could be most efficient in preventing these things in the first place, which makes sense, right? But the traditional model of medicine for many years was treating it when it became a problem. Secondary services, this is directed towards early diagnosis and treatment of illness. These services are being performed in surgery centers, offices, outpatient centers. So this would be something like surgery or some sort of diagnostic treatment. Okay, so that's your secondary. And the trend is away from the hospital because of costs and increasing specializations of hospitals, and even growing evidence of the fact that if you're in the main hospital, you have a higher chance of having an error or infection than you do in some of these smaller facilities. And then you have a tertiary service, and that's more long-term. Rehabilitation services might be care for the dying. These places were provided in extended care facilities, but now there are a lot of services that are provided in-home or in outpatient settings. All right, so members of the team, right? We have our MDs, you know who those people are, and then you have DOs, which is a doctor of osteopathy. Essentially, both of these are physicians, and they're just different methodologies within medical school. So you might see doctors from either or. The difference for DOs is that they have a little bit more training in the orthopedic aspects of medicine. Advanced nurse practice, APNs, practice nurses. So that would be nurse practitioners, and then other like clinical nurse specialists, physician's assistants. They are very similar to a nurse practitioner in the way that they practice, but they have a very different training. They're trained out of the medical model versus the nurses trained out of the nursing model. So as an extension of the physician, they practice under the supervision of a physician. Each state has different practices, scope of practice, and things like that. And there's been recent movement towards independent prescriptive authority for nurse practitioners as well as PAs. And every state's different for that. And then we know who we are, registered nurses, and then you have unlicensed assistive personnel. Those are people that you'll work with in your, for instance, like when I was in nursing school, I was an emergency room technician, and that was a job that you can have as a nursing student. And that was, I wasn't licensed, and I would do things like very similar to like a CNA, right? Anything that needs to be done that doesn't require a license. Then we have pharmacists. Pharmacists are, it's very interesting how their practice has developed over years, because they're now actually, they have some of the scope of practice of physicians. They're able to manage the primary care of certain populations. They, as you've probably seen, they can give vaccinations. Those things were previously, it was only a physician role as far as the managing primary care. And then nursing were the only people that gave shots. So pharmacists have begun to delve into those areas. They're also really great in the hospital for getting information on medication, contraindications, and et cetera. And they're a great resource for that. And oftentimes they are better than the physician with specific drugs. All right, so therapists and technologists. So then you have therapists, and that might be like, for instance, a respiratory therapist or a speech pathologist. And then you have technologists, right? Surgical techs or ultrasound techs. And so the difference between these is the way that they focus on the task. So therapists are more holistic in the way that they help, physical therapists do the rehab of the muscles and the bones. Occupational therapists work with them closely, but they help regain function and independence in activities of daily living. And then you have people like ultrasound technologists who are trained in the technical aspects of how to perform an ultrasound. And technologists are very specialized. All right, so which healthcare provider dispenses medications and therapeutic solutions in the hospitals, community pharmacies, and health settings? So we just talked about the role of pharmacists. So I'm going to go with that one. Pharmacists prepare and dispense medications, et cetera, et cetera. They collaborate, and they're very effective in their role. All right, so financing for healthcare. So there's different ways of paying for healthcare from the client. We refer to these payments made directly by individuals as direct payment of services or out-of-pocket expenses, right? Or fee for service. There's all these different ways of talking about it. If someone has individual private insurance, they pay the insurance premiums to an insurance company, and then that insurance company has a contract with them to pay for certain care, and the clients share in that cost usually with out-of-pocket expenses on some level. You have employment-based private insurance. So that's a situation where your employer shares some of that cost and you share it. And then the insurance coverage is maybe at sometimes a higher level of quality, not so much anymore, it seems like. But so that's because that cost is shared, that the cost to the consumer is less. Then there's government care. So you have Medicare. Medicare is a federal insurance program, and that was created in 1965. and that's for people that are over the age of 65. Okay. And sometimes it includes people with chronic health conditions. And then we have Medicaid, and that's funneled through the state, or sorry, it's funded through the state and federal taxes. So, and it might be through an HMO. There might be like an organization that you go through, and that's given to people that don't have the ability to afford that care, right? So that's the universal care option for people. And then you have charitable organizations, of course, that provide care for the homeless or in some cases, mental health issues. Good example of that is the Shriners Hospital, which provides care free of charge to the kids. Okay, so a little bit about diagnostic related groups. So in the early 80s and 70s, what would happen is they had these things called diagnostic related groups. And the way payment always worked for hospitals and physicians is when these were in place prior to this, they would be reimbursed at a flat rate for whatever they did, right? And they would be reimbursed regardless of the cost, regardless of the amount of uses. And so that was like the heyday for hospitals and doctors, right? But at some point, the organization, the government came in with diagnostic related groups. So this became the beginning of reimbursement of care. So they started classifying different diagnoses and specific payments related to those things. So this is the beginning of the hospital and physicians getting changed reimbursement set amounts. And so they were reimbursed based on these amounts, and it became a lot more complicated because, for instance, a physician might practice a certain way, and that's not optimized for the hospital, and vice versa. That still happens today. And also over time, that profit is dwindling because the government reduces that amount almost yearly. So usually when Medicare will change these, and Medicare does this, and when they do that, a lot of times private insurance companies will follow, because why not, right? Because Medicare just reduced the payment, so why don't we do that and we can make more money? So there's this squeezing of the clinicians and hospitals and their profitability. Over the last, since 2021 until 24, there's been a 30% increase in bankruptcies in hospitals in this country. So that's something that is a big change. And as labor costs go up, and as diagnostic related groups and reimbursement programs go down, and then the government has decreased ability to pay the bill for things like Medicare, which is supposed to be potentially insolvent fairly soon, we're headed for an iceberg in the water of an untenable situation for the cost of healthcare. That's going to create some problems for this country, and hopefully we manage that well. Okay, and you've probably noticed it, because if you're paying for your own health insurance, it's become at least twice as expensive since the CARE Act, right? And so part of that's because, well, I don't know, I really know why, because of all those reasons, but it's definitely gotten more expensive. Okay, so health maintenance organizations, that's like your Kaiser. That's the one that operates on what they call a capitated cost structure. So that means you get a certain number of dollars for every million clients that you manage, right? And so you get that pool of money, and depending on how well you manage it is how much money you make. And that's similar to an insurance model, right? And Kaiser is an insurance. So it's like a life insurance model. The better job you do, the more money you make. And so they have cost structure containment strategies to keep certain things from being done unnecessarily, right? And that was always the knock on Kaiser is, they'll restrict your care. And that's why physicians that was their mantra for a long time. And now there's, a lot different view on that. Preferred provider organizations, these are PPOs. This is where you have more flexibility than an HMO. You can see a specialist instead of being required to be referred like an HMO might require. And then point of service is, and also called fee for service, is where you combine the features of an HMO and PPO, and you can select a provider from a list of networks. And then you have that person, but you can also see out of network providers that will you can come out of pocket for. And then IDNs are integrative delivery systems. You might hear somebody talk about healthcare systems, and that would be a Kaiser Permanente or a UC system or Sutter Health. That's the larger system. All right, so healthcare reform. In 1980 something, late 80s. No, actually, I think it was early 90s. Anyway, George Halverson, who was the CEO of Kaiser at that time, he wrote a book called Reform Healthcare Now. And that book stated in it that if we manage the top 5 chronic diseases in this country really well, we can reduce the spend of healthcare in this country by 80%. So that was a pretty revolutionary idea, that by managing things like congestive heart failure, diabetes, cancer, and that 80% of the fees that we pay for in healthcare are in the last 6 months of life. So that put that together to say, if we manage these chronic conditions and we manage them at the right time, we can significantly reduce the amount of cost. So that began the healthcare reform discussion. There's always been one, but that really put some teeth to it. And the ANA has some recommendations for this. And so they recommend, in their position, is that we need universal access, and we need a adequate supply of a skilled workforce. And then we promote ways to stimulate economical use of healthcare services to maintain the viability of it. And then we optimize the selection of care based on what is the most appropriate and efficient way to do that. So you'll see things in the hospital, things like work redesigns. They're all created to help the efficiency and value of nursing and healthcare. You'll see things like pathways that are pre-developed to help people treat certain ways in the way that has the highest quality, but is also the best use of resources. Then you'll also have people like case management who are now focused on that, and the organizations will pay money to dedicate them to finding problems within the fragmentation of healthcare, and that will help them manage their costs as well and the quality of care. So there's a lot of argument between the right to have healthcare or the right to, or is it a privilege? And this is something that has been asked for many years. Every country is different. There are some countries that have socialized medicine, and they have certain strengths. America has a fee-for-service model where it's universal, but it's still very profit-focused. And for instance, you might have Medicare, but you might find it difficult to find the same quality of physicians that people have with private insurance. And so those are some of the challenges. And so you'll see this as an ongoing conversation, particularly big organizations in nursing like the ANA or nursing unions. They're, of course, very focused on the healthcare for all concept. And that's just something that, we're trying to sort through and see, because of course the healthcare for all increases the cost of healthcare. There's some that say it may not increase it as much as we think if we manage those things well. But of course, there's a risk there, right? There's always there's a discussion of what it can do, and then the policy is put into place, and that can be something very different. All right, ensuring quality of care. So continuous quality improvement is something that you'll see throughout your career. And essentially what it is performance improvement. We are constantly looking at our process to improve the way we create care, We're always doing process reviews. We're also looking at outcome reviews, and you'll be doing chart reviews or monitoring clinical outcomes throughout your career. And these are all things that are designed to improve the quality of the care as we go along, and they do. Societal trends, as we were talking about our economy, health insurance is mostly provided by employers. It's become more regulated, and in California, for instance, it's in some cases required of the employer, regardless of size. And but regardless of that, it's becoming more and more expensive. And the question of our ability to pay for it in the current increase is under scrutiny. The medical inflation rate in this country can go anywhere from 5 to 20% every year. So if you know anything about what inflation is, prior to the last 4 years, inflation was typically 3 to 4%. And so if medical healthcare is going up 15% a year, then you have a very different picture of what the future of healthcare will cost versus what the future of goods will cost. And so that's a problem, right? That indicates that eventually there's a collision course there. We have a growing population of adults, which tend to be more expensive to care for. And on the positive side, consumers are now becoming much more informed because of the access to information. Legislation is also controversial, but in many cases it's used to create incentives to take us in a direction, one or the other, that we want. And collective bargaining, I talked about unions before. That's a form of negotiating that nurses are engaging in, and by binding together, they have a stronger position on improving things like their wages or their benefits or working conditions, et cetera. And again, that's a challenge too, because there's lots of burnout in nursing, and lots of talk about that, but also the pay rates that are happening in nursing because of the difficulty to keep nurses in nursing is becoming, it's putting pressure on our ability to be financially feasible. And so that's why you've seen the increase in bankruptcies in hospitals in this country. All right. So trends in nursing, you might see more complementary and alternative medicine. There's a lot more people doing chiropractors or acupuncture and all those things, even insurance companies covering them. You're going to see more care locations, smaller satellites, more professional collaboration, and expanded career goals for nurses, and using unlicensed assisted personnel to supplement the cost. And also the influence of nurses on health policy. We have a big say these days in how that's being conducted, and we should, and that's positive for us. And then high tech is hopefully, going to help us over time. Traditionally, it's been the opposite for us, because in America we spend the most money per capita in healthcare, and we actually have about, I think at one point we were number 20 in the world in quality outcomes. And so doesn't track, right? So for some reason, we have passed the law of diminishing returns, where we're not getting quality out of the amount that we spend anymore. Although quality care, someone might argue, is pretty good in the US, it's not, it's decreasing in value based on the spend that we have. All right, so that's all we have in this module, and then we're going to go into our next module, continuing this recording.